Hey, thanks so much, Julia. Thanks for that introduction. So yeah, again, I'm going to talk about Mycoplasma pneumonia today. Before I get started, I do want to share that funding was provided by the Kentucky Department for Public Health for this grand rounds. There was no commercial support, and I have nothing to disclose. So today I really want to talk about Mycoplasma pneumonia, the bacteria, how it's different from other respiratory pathogens or the symptoms are different, the appropriate treatment for Mycoplasma pneumonia infections, and then what things we can do to help limit the transmission of this and control the outbreaks. So if you have eyes, you have seen these types of headlines recently about the increase in Mycoplasma pneumonia infections, especially in kids. So what is it? So it's a bacteria. It does cause respiratory illness and it can cause pneumonia. Now, before COVID, Mycoplasma pneumonia caused about 2 million illnesses per year in the United States. Like many of the respiratory pathogens, it can happen anytime during the year, but we see it primarily in the winter and those in the respiratory season between October and about February. Um, Despite these kind of little spikes every winter, we did see higher outbreak numbers about every 3 years. Now, when we had COVID, and especially that first year when people were doing a better job of masking, social distancing, and not going out if they didn't need to, we saw a real significant decrease in the numbers of kids and adults that had mycoplasma pneumonia. Now, this comes from a paper, I believe from 2022, that was actually titled Mycoplasma pneumonia, where is it? We saw this decrease, and this is actually from Switzerland, but they were looking at kind of the respiratory pathogens that we typically see. That black line that got really tall there, that was COVID. The red line at the bottom was Mycoplasma pneumonia. They really saw almost no cases at all in Switzerland. They predicted in this paper that once M pneumonia came back, it was going to come back with a vengeance, and they were absolutely right. In November of 2023, I think China was the first who publicly stated that they were seeing a reemergence and then a significant increase. But shortly thereafter, Europe, Asia, and Australia noted an increase, sometimes four times as much as what they would typically see before COVID. And then around that same time in early 2024, the US began to see this. So this at the bottom, this shows test positivity between 2016 and 2024. So you can see that, with 2016, there was, 2015, 2016, we had kind of that every 3 year spike. We have that seasonal increase. Then there's really very little for a year and a half, 2 years. And then the end of 2023 and beginning of 2024, we see a huge increase. And compared to what it's been for the past, 8 years, significant increase. For Kentucky specifically, I was able to get this information from the Kentucky Department for Public Health. Now, this shows weekly cases. These are hospital encounters, so these are not urgent care visits or visits to a primary care physician. But this shows the cases the last 6 months of last year. So from July 1st until the end of December, just 2 months ago. And you can see that nice increase through the second half of the year. And Jefferson County specific just really reflects what we saw across the state. And then I wanted to look back a little further so that I was able to get this information. This is monthly cases, again, hospital encounters in Kentucky from January of 2019 until just December of 2024. And so, again, we never really saw that huge decrease the way we saw in other parts of the world and probably in other parts of the United States. But we can certainly see that the last 6 months or so, the last 6 months, this has really increased. And again, Jefferson County reflects that same pattern. So again, this is a bacteria. It's a little bit unique. It's a rod. The thing that unique about it is that it doesn't have a cell wall. It's very, very, very tiny. So it's difficult to see with like microscopy. It grows very slowly. And you can see that that unique shape in those little those little pokey tips. So what happens is when this gets into the lower respiratory tract, that tip is able to poke through the epithelium between the cilia. Now, once it's able to get in there, of course, it's going to begin to multiply. It's going to cause inflammation. It's going to get the immune system revved up. So we're going to have some inflammation. It's going to injure those epithelial cells, and it will inhibit ciliary movement. So remember, the cilia are those little hair-like projections in the airway that are consistently waving up towards the top of the airway so that we can cough out any mucus or pathogens that have been caught in that mucus, or we can swallow it down and get rid of it. That's ineffective during some of this infection. Um, M. pneumonia is also able to alter its cell membrane to more closely resemble the cells on the human, the membrane on the human cells. And that makes it much more difficult for the immune system to identify it and attack it and get rid of it. So symptoms almost universally are going to be upper respiratory tract infection. Now there are people who get this and they never really have any symptoms, but of those who get it, typically congestion, may have some sore throat at the beginning, might have a little headache, runny nose. Younger kids might also have some of what we see in our typical viral infection. So they might have some GI symptoms, can have some wheezing as well. Now, this will or often go down into the lower respiratory tract. So in that, we're going to have this prolonged period of cough. It's just a cough. It doesn't seem to go away. There can be fever sometimes, usually not a high grade fever. And of the kids or adults, I'm from a kid background, so I always think of kids. About 10% will actually develop a pneumonia. Now, it's important to know that these symptoms are typically very, very mild. And this is one of the reasons that it's called a walking pneumonia, is because even though it's a bacterial pneumonia, it doesn't behave, and the symptoms aren't similar really to other bacterial pneumonias. Typically, when we have a bacterial pneumonia, um, we feel terrible. We have respiratory symptoms, fevers, and we just feel awful. And most of the time, even with this pneumonia, we're behaving pretty normally. Might have, decreased energy and decreased appetite, have this cough that just seems to last forever, but typically not so sick that I'm just lying in bed and can't get out. And even for these kids that develop pneumonia, most will recover without having any sort of antibiotic treatment. Now, one thing I do want to mention that can happen, and we do see this probably more often than any other complication, are mucocutaneous symptoms. This is called MIME. It used to be called RIME, but it's a reactive infectious mucocutaneous eruption. So, of the kids who get this, most will have an oral involvement. So they'll have crusting of the lips, they'll have erosions in the mouth. These can be really painful. And certainly, if any children get this, they would need to be evaluated because this can mimic like stomatitis or herp angina or something like that. So we want to make sure that it's being treated effectively, that it's diagnosed effectively, or, appropriately, and treated effectively. But for kids especially, this can cause some dehydration because it's really uncomfortable, and younger kids especially will refuse to drink due to the pain. Many can get conjunctivitis sometimes with that goopy discharge from the eyes. What we are going to see most often with this is just a rash, typically on the trunk and extremities. This is usually a maculopapular rash. Typically, it's not itchy. It doesn't really cause any issues. Of those who develop a rash, about 60% will also have that rash on the genitals, which is something that's a little bit unusual, but it is not, unheard of. Saying that, these skin lesions can vary. So again, most of the time, what we're going to see is a really, really mild rash, but these lesions can become large. They can be blisters. They can be just really nasty. So if those rashes or those lesions develop, they do need to be evaluated. These are some pictures of some of the lesions you might see or the eruptions you might see in the mouth, and then of course conjunctivitis. For this picture of the rash, well, again, that picture on the left, it's a little bit hard to see, but that's the typical sort of rash. It's something where we look at it, we go, that's not normal, that's not right, but it's not super concerning. These pictures on the right show are some examples of what this rash can look like. Certainly, you see that mouth. That's going to be a kid that needs some hydration and some pain control because those eruptions in the mouth can be really really painful. And again, those rashes, that doesn't look normal. That's something that we would certainly want to have evaluated to make sure that we don't have something else going on. Now, when we think about the common causes of pneumonia for kids, especially, most often pneumonia is going to be caused by a virus. When we look at bacteria, under the age of 5, strep pneumo is going to be the most common cause, and then we have H. flu, staph, MCAT. For kids age 5 and older, again, strep pneumo is up there high. Then we have mycoplasma pneumonia and a few others. So we typically don't see mycoplasma pneumonia in kids, excuse me, under the age of 5. This is something we think of as a school age bacteria. What we've found is that with this recent increase, we're seeing this in kids we typically don't see this in. So this is showing these are ER visits that resulted in pneumonia diagnosis. I've kept 3 of the lines up there. That orange line are kids that are 2 to 4 years old. So an age group where we usually don't see this, or we see it very rarely. And you can see that is the highest number in the US, especially, at the last half of the year. That was the age group that was seeing, we were seeing this in the most. So when we think about how does this spread? Well, it's spread via respiratory droplets. So just the way that many respiratory illnesses are spread: cough, sneeze, being in close contact with somebody. So again, those in crowded settings are going to be at an increased risk. So that's people that are incarcerated, dorms, the settings for in the military, certainly in the family unit. Now, the incubation period, once this is spread, can be 4 weeks. And again, some people never develop symptoms, but during that time, they are contagious and they're spreading this. No one knows they're sick. No one knows they're getting this. So a lot of times precautions aren't being taken. Now, I mentioned before that this was commonly seen in the winter, and we get about 1% of the population that's infected per year. So how do we determine that this is what the diagnosis is? So in kids, we usually don't do any special testing. We are usually able to determine the diagnosis just with physical exam and history. The symptoms, again, are a little different than a lot of other illnesses in that these, people typically tend to have some cold symptoms. They end up with a cough that just lasts and lasts and lasts and doesn't go away. We can do a nasal swab, to PCR to check. We have the ability to do those swabs and get a pretty quick result for certain pathogens. So for COVID, certainly we usually can do those quick swabs. We're all used to that. We can do this with RSV and with influenza. I don't know that there's a quick test, a point of care test that can give us results for mycoplasma pneumonia. So in that case, you would be doing the nasal swab and not getting results for another day usually. Chest x-rays usually aren't necessary, and we typically aren't going to get any labs. With adults, it's a little bit different. We do get imaging much more often in adults. The older the adult, they're typically going to have more comorbidities, and so it's a little bit more important and a little bit more difficult to tease out the cause of a respiratory illness in adults. So typically, imaging, it's easy to get, and it can help determine if this is an exacerbation of an underlying problem or an infection. I can again get that PCR. And then depending on the patient, the presentation, and the comorbidities, we may get a sputum sample. We may get urine to test for antigen testing to test for like strep pneumo, and then we may get blood cultures. Now, when it comes to testing, mycoplasma requires a really specific environment to grow in, and it can take many, many days. So we typically don't get cultures. Now, certainly if someone is in the hospital and they're very, very sick and we're trying to tease out what is causing their illness, we may get it, but typically, even for people that need hospitalization, we're not going to try to culture that. And then antibody testing can be done, but again, it's unreliable. We can have this infection and we may have no antigens at all that are detectable in the first several weeks while we're sick. And then we can completely recover and our blood will show those antibodies after we're better. So it's not quite reliable. When we think about treatment, so the thing that makes again that makes this a little different in children, for children who develop community-acquired pneumonia, our typical treatment is a penicillin, usually going to be amoxicillin. Now, because Mycoplasma pneumonia doesn't have a cell wall, and penicillins work by attacking the cell wall, the typical treatment for pneumonia in kids is completely ineffective for Mycoplasma pneumonia infections. So for children, the frontline treatment, the first line treatment that we're going to do is a macrolide, which for kids is going to be azithromycin or cloberazithromycin. We can do doxy for kids that are a little bit older. And most of the time, we're going to see improvement within about 48 hours. For adults, it's going to be really those same medications, a macrolide, doxycycline, or we can do tetracyclines, and then fluoroquinolones. Fluoroquinolones we typically don't give to kids, although I've given it to older teenagers, 16, 17 years old. Now, in the US, macrolide resistance is less than 10%, but that's not true throughout the world. In China, macrolide resistance is over 80%. In Japan, it's over 50%. If we start to see a lot more macrolide resistance, or if we have a patient who's sick and needs medication and there is macrolide resistance, we probably are going to have to talk with ID because the treatment options are so much more limited, and especially in young kids. We just don't have the medications that are approved for young kids. But again, this may be a situation if we see a lot of resistance where we have to give medications that we typically wouldn't use in young kids. Now, I do want to mention that prophylaxis wise, we typically don't give prophylaxis. In the case that we do need to give it, it's typically will be a macrolide. Now, with adults, I wanted to also point out that the typical community-acquired pneumonia treatment for adults will cover mycoplasma, even if it's not diagnosed. This is hard to read, and I don't necessarily need you to read it, but I wanted you to see kind of the algorithm. This is available and up to date that kind of can help clinicians decide their treatment plan. And it asks things about, comorbidities and whether they're currently taking antibiotics, are they smokers, that kind of thing. And it helps determine the appropriate treatment. Even if mycoplasma isn't identified, the typical treatment will cover mycoplasma. And that's the true for inpatient treatment. So a patient, an adult who has community-acquired pneumonia that's sick enough to require hospital treatment, again, a nice algorithm to help determine the appropriate treatment. But again, the typical treatment will cover mycoplasma. Now, as with anything, again, this is super typically a very, very mild bacterial illness, but there can be complications, of course. So this can cause an asthma exacerbation. For those who have asthma, it can cause wheezing in people who've never had wheezing before. Very rarely can cause encephalitis. It can cause hemolytic anemia, which we would see with the decreased hemoglobin and increased LDH retic or unconjugated bili. This is not uncommon, but this is typically very mild and does not require any sort of intervention. Of course, there are some folks who can get a really serious pneumonia out of this. And then again, that rash and mucositis that I've mentioned before. Now, I wanted to look at kind of the other respiratory illnesses that we're seeing in Kentucky in the area. So this shows us about the last year in Kentucky, and this shows COVID, flu, RSV, and then influenza-like illnesses. And you can see these are still pretty high numbers. And I know that I don't have the most up-to-date information, but I know that flu is still very, very, very high um, in Kentucky and the United States right now. So again, how do we determine what a patient has? And this table just really kind of shows. Now I have mostly viruses on here and then M pneumonia, and I put that on there specifically because this does often act similar to a virus and not a typical bacterial infection. And because viruses, these first the middle three columns here can vary from person to person. We know that people that got COVID who had very mild symptoms, and we know people that got COVID that had very terrible symptoms. So typically, the onset of COVID symptoms is kind of quick. People typically would have respiratory symptoms, and then they tend to have those symptoms for a day or two and then start feeling worse, and they can have body aches and fevers and fatigue and difficulty breathing. With flu, it's usually very sudden. These are folks that seem okay, and by the end of the day they just feel horrible, and that's usually body aches, fever, and chills. Viruses, can vary depending on the virus and the age of the person, but a lot of times we're not seeing usually high fevers and chills and body aches. A lot of times it's going to be those cold symptoms like congestion, sometimes wheezing, especially in young kids, decreased energy and decreased appetite. With M pneumonia, again, this is a very insidious onset. The people typically are not having high fevers and body aches and that kind of thing, but they will have cold symptoms. They can have wheezing. But it's again this very prolonged cough. A lot of times, parents would bring their child in, and it wasn't that they were suddenly worse, that they'd had this cold and suddenly it was worse. It was just like they've had this cold and this cough, and it's just not getting any better. So again, a lot of times we're able to tease out what we think this is and our most likely diagnosis just with a history and physical. Now, as far as trying to prevent this from transmitting everywhere and getting everyone sick, using our typical respiratory etiquette, so coughing and sneezing into our elbow, using good hand hygiene. There's nothing special about M pneumonia that makes it very difficult to kill on hands or on surfaces. So typical hand hygiene and typical cleaning. Certainly, if you or someone has these respiratory symptoms, has a cough, they need to wear a mask. Certainly, if you are immunocompromised or you're concerned at all about your health and you're going to be going out into public, wear a mask to protect yourself. If these are folks that are being seen in a healthcare environment or they're going to be admitted to the hospital, they need to be in droplet isolation. So that means if they're out of the room, if they're moving about and they're old enough and able to keep a mask on, they need to have a mask on to protect others. Any healthcare workers that are going into the room need to make sure they're wearing a mask, eye protection, gown, and gloves. And of course, we always want to recommend our routine vaccines. We certainly, Mycoplasma pneumonia, while it's not the worst bacterial infection to get, certainly puts you at risk for co-infections. And there's no reason that you have to get a nasty strep pneumonia on top of this. So we always want to recommend those vaccines. And then takeaway points, this is an unusual and atypical bacteria that causes respiratory illness. It's very common. The US and Kentucky are currently experiencing very high rates of this, along with our surge and other respiratory illnesses, especially flu right now. We are seeing that increased number of cases in kids that are under the age of 5. And so when we're seeing patients of all ages, not those that are just school age through adults, we need to keep M pneumonia in mind when we are evaluating these patients and determining treatment. When we diagnose a patient with pneumonia or really anything, and they're not improving the way we would expect them to improve, especially if we're treating a patient for a typical bacterial pneumonia, we need to reevaluate them and determine if there's further testing that needs to be done or if we need to change the antibiotic therapy. If we have a young child that's being treated with amoxicillin and they are not improving, it's day 3 and there's no improvement or there's worsening, this might be, even if that child's not in our typical age group for pneumonia, might be a time when we need to either test or go ahead and switch them to an antibiotic that would cover those atypical pathogens. So I think I have some time left, and I'm happy to answer any questions if anyone has any.
Anyone have any questions for Melissa? All right. Well, thank you very much, Melissa. I know that respiratory season has been quite impressive this year, and obviously having this circulating about isn't helping things. So, um, thank you very much, and we will see you all in 2 weeks at our next grand rounds. Thanks.